The last speaker, Dr. Gaurav LUTHRA, who's a dear friend of mine. I was supposed to go to his course, but I had no one here to take care. So, Gaurav, please, last 5-10 minutes, whatever you would like to show. He's got a phenomenal practice. Everybody knows Gaurav. He does a lot of live surgeries all over the country and internationally. He's from Dehradun. He's going to talk about his oops moments in cataract surgery.
Thanks, Kumar, and very good afternoon, everyone. And you can see one of those oops moments right there, and I'm sure some of these have already been covered during the session. And I wanted to just showcase this one video. I was doing a posterior polar cataract, and I'd done a lot of planning. I like to do a femto-assisted surgery with leaving behind a cushion of about 700 to 800 microns of the epinucleus, and no hydrodissection but a good hydrodelineation. You can see that I'm following all the rules of posterior polar cataract removal. I'm removing only the endonucleus, no rotation, and trying to ensure that I leave a good epinuclear cushion to right till the end. So things go well. I'm putting in viscoelastic when removing the instrument from there. Once the nucleus is gone, you can see on intraoperative OCT that everything was in good shape till before. You can see that it's nicely stuck to the posterior capsule. So I don't want a fluid wave to go over here. So I'm going to go on, and now by manual I'll disengage the cortex and the epinucleus from the equator, make sure that on all sides I've debulked the epinucleus shell so that the last part is the central core which is attached to the posterior capsule, and I'll let it float up with either infusion or with hydrofusion or with viscoelastic. So you can see that I'm not aspirating, I'm just disengaging it, and all this while my posterior pole remains intact, and I'm focusing on that posterior pole. Now you can see a small plane beginning to develop. You can see the plane of hydrodelineation happening over here, so it's beginning to separate. And this is a better way to let it happen, because once that separation has happened, then I can actually aspirate it very easily. So I've managed to do a good job, and everything looks good. You can see that that area is still secure, and I'm now going to implant the lens. The lens is implanted. You see that small area of attachment. Everything is great. I'm very happy that my surgery has gone well. I'm beginning to close up the case, and I'm just putting infusion, and you see what happens. So I did everything right, got everything right. The lens was in place, and all I did was from the side port, I was just closing the eye, and I managed to break the. So in a posterior polar cataract, till your patient goes home and comes the next day, it's not over, and you can get a posterior capsular break at any point. Now this was an intumescent cataract, and I typically like to decompress these lenses. So I'm going with a 26 gauge aspiration to make the aspirate a little bit of fluid from these lenses and just see what happens. You probably didn't see it happen, but let me show you again. As it went inside, there was a sudden entry, and I created a radial tear in the capsule here. So that was a sudden entry because it was facing some resistance. So instead of creating a controlled tear, I now have, just see that movement happening again. It goes in suddenly, just watch. I should have been stabilizing with the forceps. Now that small movement, it didn't look like much, but it went and created the radial incision, and the cut has gone right till here, beyond the edge of the rexus that I was planning. So anyway, I have to manage it, and I'll go around it. I've created the flap now from both sides, and I will just try to go all around it and see if I can come around. And obviously I'll have to go quite wide, because and in an intumescent cataract, it's not a good idea to go that wide. So under heavy viscoelastic, you can see that I'm a little worried now because it's going a little bit out of control. So I'll have to pull it in. I'll probably try to use a Brian Little's maneuver after injecting some more viscoelastic there. And with that, I'll be able to bring it in and complete the rexus. So it worked out. Sometimes it doesn't work out. This was a black-brown cataract. I was doing a femto-assisted surgery, and I thought I was doing a good job. Everything planned very nicely. It looks beautiful also, almost like a flower over there. It's a very hard cataract. I get the fragment separated, and I'm able to remove the cataract quite nicely over there. But now you can see that the posterior capsule is bulging forward, and I will now go and do a bimanual cortex extraction. So it's a very floppy kind of a bag, and there is some upthrust, and the capsule is bulging forward when the chamber is lost. So I managed to do a good job so far. I'm now removing some of the cortex from all areas. This is a little bit fast, but now just see what happened. I caught the bag, and in that, I didn't do the surgery this fast, but I've caught the bag. It was just fast forwarded for you to be able to appreciate what was happening. So I've got the bag, and now I've used reflux, and I've switched on the infusion, so things are looking slightly better. But now I'm in a situation. So in that situation, I forgot that I have to inject viscoelastic from the side port. I just came out, and now just see what's happening. There is that upthrust. The bag is crumpling to one side. I quickly panic. I push in viscoelastic, but that makes it worse. Now the bag has gone towards 6 o'clock. Half the bag is gone. Now I realize that I should have pushed in viscoelastic. So this was a big oops moment. I should have put viscoelastic from the other side port and inside the bag to inflate it rather than push it from the main port and try to, make it like worse than what it was. So essentially now I'm in a situation, so I'll manage it. I'll put in a CTR and I'll probably be able to save this eye. But this is something that you should never do because it can cause a problem. A very similar situation to what this was in live surgery in Amritsar. I was getting ready to do the live surgery and everything looked very nice, and I'm all set, and I have a few people standing aside, and I'm going to make my first incision. So there I'm going with the side port. I like to make my side port with angled side port knives. I was given a MVR, and just see, I've created a small nick over there, just like in that first case. So this happens in live surgery quite often because you're using instrumentation which is not to your liking and what you don't use routinely. And I never use these MVRs, and this is a straight MVR which is very unorgonomic. So anyway, once you're in this situation, now I had 3 people around me, and if you look on the top side here, you'll suddenly see 3-4 stalwarts hanging around me, trying to guide me how I should manage this. Amongst them Dr. Kumar and Dr. Rohit Prakash and Dr. Mahipal, I remember, were all around and trying to give me tips on how to handle this. So we thought of several things, but there was no consensus on what we should do because getting around it was looking like a very unlikely task. So we eventually went in and created a rhexis which was separate from that nick. So I've created a small rhexis, and I've not gone into that area at all, and I've left that untouched. So I will be able to complete the surgery from this new rhexis, and that part will remain like that. So this was a new thing that I learned in live surgery, was that you can still manage it with the nick, and you can see that I've managed to get the cataract out, and that nick remains undisturbed right till the end. And then eventually I put in the lens, so things go smoothly over there. So I think I have a few more, but we've run out of time, so I'll just stop here. Thank you so much for giving me an opportunity, Dr. Kumar.
Thank you, Gaurav. Any questions? I think that case I was there when he did this, and that you saw that nick. Normally we panic because, and to his luck or his good technique, the CCC did not join the nick. Otherwise, if that joins the nick, it can still further go ahead and touch the equator, and worst case, it can go around and have a problem and nick in your posterior capsule. Would you like to say something?
Yes, it is good to have sharp instruments. Otherwise, you're pushing the eye. And what I'm doing, I'm putting a finger here. Counter pressure. Yeah. Yes. All the time, with main and with step.
True. So, of course, all of us, we are used to either an MVR or a side port, whatever you are all used to. But all these things can suddenly happen in your surgery, and it can suddenly surprise you, but this is just a quick tip as to you can still manage these tough cases this way. Thank you all very much, and thank you to the panel.